welcome Professor Dame Lesley Regan. Hello, Lesley.
Hello, Asha.
I nominated Lesley, and you can read the full citation on our website, but here is a little overview of why I felt Lesley richly deserves our honorary fellowship. Lesley, congratulations on being awarded the honorary fellowship. And
can I say thank you to you and to the faculty? I feel this is a great privilege, and I'm very, very, very honoured to be given this honorary fellowship. Thank you.
I'm absolutely delighted because we've known each other quite a while. We worked together so much as presidents of you of the RCOG and me of the faculty, working together for the betterment of women's health. So it is an absolute pleasure for me to be awarding you this, but also to have a chance of finding out more about you for our members. I want to start by asking you what brought you into medicine, Lesley, and particularly into women's health?
Well, I don't know what brought me into medicine, apart from the fact that I announced to my father at the age of 7 that I was going to become a doctor. There were no doctors in our family, no nurses. My father came from a very, very poor background. He came from a slum in Cardiff. He left school at 12. And looking back now, I took it rather for granted that I would go to school and then go on to university, but I was the first person in our family that ever finished secondary school, certainly the first that went to get a university degree. And I often look back, Asha, and think that if my father hadn't had that vision that girls should be educated, my life would have been very different. But I got to medical school. It was a bit of a struggle because I was a complete dunce at maths and physics, but I got there. And then when I got there, within a very short space of time, I met a mentor there, a wonderful woman, an obstetrician and gynecologist, who just every year picked 2 or 3 of us and said, you're going to do obs and gynae. And so it was sort of slam dunk organized from the end of year 2. She was a fantastic influence on me, and that was my path. And then things melded on. I went to Cambridge, and there I joined a very busy unit, and it was the first registrar job I had, and suddenly found myself, in charge of a very busy labour ward and big emergency department. And I kept finding women at 3, 4 o'clock in the morning, usually on Saturday or Sunday night, who were so distressed because they'd miscarried. And I couldn't find much information in the textbooks about why they were miscarrying. And so I met another mentor there, or 2, a clinical mentor who really taught me how to operate. And I've never forgotten that. And he still sits on my shoulder when I'm operating. And if I try to take a shortcut, he just goes, hang on. All those years later. And I met another wonderful mentor who said, well, if there's nothing in the textbooks, then you'll have to do some research. And so I started off a very small research program in miscarriage and the causes of miscarriage. And then, as you know, I then developed a sort of a national and an international reputation for recurrent miscarriages. But that was sort of during my early years of training. And then in 1990, I was appointed to my first consultant post, and it was a senior lecturer post. I hadn't planned to do any more research, but the job came up, and there I was with sort of this specialist expertise in repeated miscarriages. But I took over David Paynton's job at St Mary's Hospital, Paddington, who, as you know, was an enormous champion for NHS day case abortion care. He worked with David Steele on implementing the 1967 Act, and in 1990 he retired and I took over from him. And a lot of people said, well, this is very strange, you know, you're doing miscarriage half the week and abortion care the other half of the week. And I said, well, it's not strange, it's because I know a lot about early pregnancy and I want to support women to be able to make choices. So that's how I really got into obs and gynae, and that's how I've sort of focused into reproductive medicine. I was really interested in early pregnancy and also providing women with choices. So of course the obstetrics was lovely and it was wonderful and fun and exhilarating, but at the end of the day, I thought helping women to do what they wanted with their fertility and with their lives was also very important. And I realized that I had the skills to be able to improve the quality of their life in those aspects. And so that's what I did for a long time. And then as my recurrent miscarriage program and my research team grew and grew, I then sort of put in a bid to the hospital to ensure that we protected our abortion services, and we became, as you know, quite specialist in late surgical procedures and medical procedures. And they fortunately listened to how important this was as part of women's healthcare, and they appointed a consultant team to do that. So I rather drifted away, not drifted away, but I focused then on the recurrent miscarriage, comfortable that we protected the other side of early pregnancy and the abortion services. And I think, you know, life went on like that, doing various things. You know, I enjoyed traveling. I did quite a bit of global health work, and always then the understanding of how miscarriage is just the flip side of the coin of abortion care was really helpful in helping me to work overseas and help influence policy overseas. But my real sort of focus on women's health, i.e. promoting health, as opposed to what I'd done up until then, which was working in a disease intervention service and helping women when they had a problem, as opposed to helping them plan their lives across the life course. That really came in 2010, and it was two things, that, both of which were opportunities that came out of the blue. And you've heard me say, Asha, many times, you know, opportunities rarely make appointments, and if you don't grab them while they're going past, then you'll miss them. And in 2010, I met an amazing woman who was running a leadership program in the United States for women medics and dentists and academics. Met her, and she said, oh, you should come on my program, because you know, you don't want to just carry on being a doctor and doing this. If you want to really explore women's health, you need to. And I did. And it was quite a struggle to get there and do it, because it involved traveling to the States 3 times in this year. And so I took leave and And then that same year, I heard Sir Michael Marmot talking about the social determinants of disease. And it was just like a light bulb moment. And I really thought to myself, what he was saying was, it was a simple message, but it was very, very moving, that the healthcare that you and I have been trained to deliver only supplies 1/3 of it. And that 2/3 are determined by where you live and where you work, how you were educated. And I guess that was why I mentioned my father earlier, because it could have been so different for me if I hadn't been educated. I was born in the 50s, and you know, lots of girls didn't finish their secondary education. My mother, for example, thought I should leave school at 16. So it could have been very different. Anyway, I heard Michael Marmot. I was just so amazed by it. And it was at this time I had this leadership course away, so I had time to reflect on it. And I came back to London and I thought, I've really got to do something about this. And at the time, Sally Davis was our first chief medical officer, just coming into post, and she was very supportive about trying to get these things up and running. And she encouraged me to go into the Royal College, and I went there as a council member, first representing international work and to help with the work I was doing in sub-Saharan Africa. I then got a very lucky break, because I was approached by the large anonymous donor to see whether I'd like to run a program. And that's when I think I first really linked up with the faculty, because I wanted to do this collaboratively. And we set up the Leading Safe Choices program to improve abortion care and postpartum contraception in sub-Saharan Africa. And I felt very strongly that I didn't want to reinvent the wheel. I wanted to do this collaboratively with the faculty. And your fellows and members were so generous and helpful. Together, I think we created something which we were both colleges were very proud of, and it really made a difference. And that gets me to about 2014. I then applied to be vice president. And and got very excited about the fact that all this time I've been doing these other things, that abortion care in the NHS seemed to be drifting away, and that we'd sort of, a whole generation, my generation of gynecologists seemed to have forgotten how important it was, or they weren't prepared to deal with it. And with your help, I set up the abortion task force. Everyone said, you won't be able to do this, you'll never be able to get the independent sector and all the people with polarized views to agree. But by carefully and respectfully listening to everybody's viewpoint, we managed to get the task force together. And I think, Asha, what I look back on, that was a time when I got to know you very well, and other members of the faculty like Anne Connolly and so many of the others. And I think that what we demonstrated was that collaboration is the name of the game if you really want to make a sustainable difference. And that I think, I know you believe this too, but I'll just say it as we're here for this special occasion, that you can travel a lot farther and a lot faster in life if you don't care too much about who gets the credit along the way. And so I think we really set that up, the abortion task force. And when I look today, you know, I can now go to Westminster and talk to ministers and talk to people about in the Department of Health about abortion care and the importance of contraception and allowing women to determine what happens when they have sex as opposed to just being imposed on them. And we couldn't really do that 5 or 6 years ago. It just wasn't possible. So I think between us, we've managed to get these topics into common everyday speak. And I think that's possibly the most important way forward for women's health.
Yeah. I mean, that's absolutely an amazing story, Lesley. It's also, it gives people hope, isn't it? That whatever background you come from, you can reach the very top. You have to have determination and courage, which you have in absolute abundance, and I've seen it very closely.
Well, I think it is difficult because it can be difficult. And I just, for anyone who's listening, who's more junior to me, and I think most people will be, I think if you believe in something and you just need to be patient and keep going on with it and focusing on something that you really care about and which makes a difference. And what I realized in retrospect is it's very easy to have a niche area like recurrent miscarriage or, I don't know, minimal access surgery for fibroids or endometriosis. But if you really want to make a difference to women's health, you have to work out, or you have to think about what are the things that really affect their lives. And being able to control their fertility and decide if, when, and how many times they become pregnant and with whom. And, you know, things like just being able to manage their periods. You know, when I said to a minister not so long ago, well, you know, I don't understand why we can't talk about menstrual periods, because most women have 12 of them a year for 35 years of their life. This is normality. So we need to get the girls in schools to understand that, and the boys too, so that they can ensure that they have the best quality of life. And then, of course, what you and I have discussed on some occasions, Asha, I'm going to be 65 in a few weeks' time. So I know that I am the first generation of woman who's probably going to live longer menopausally or post-reproductive than I was reproductive. And that's not happened before in society. So I think it's really important that we focus on how to make the quality of women's lives in the post-reproductive era as good as it possibly gets. I don't want to live forever, but I want to live well while I'm alive. And we do very little, I think, for women after the age of 51, when that's the average age of menopause in this country. And I think we should do a lot more, because they're not well catered for. Once again, we go back to disease intervention there. We wait for them to have a problem, and then they present either with a cancer or heart disease or with symptoms of frailty, because they break a bone and then things go tumbling down after that and they become dependent on others. And I'm sure, I know you feel the same as me, that I don't think we should be going on forever and ever, but whilst I'm alive, I want to live as independently as possible.
That brings me really neatly to my next question, is what about your future plans when it comes to women's health? What are you doing now, and what are your future plans?
Well, at the end of my 3.5-year presidency at the RCOG, I was very lucky to be heading up a team in the policy and press unit who were fantastic young people. They were just fabulous. And they put their absolute all into producing that report, Better for Women, which we launched at the House of Commons in December 2019, just before I left office. When I reflect back on it, Asha, it was the most amazing party. There were about 300 people there, and you with your mask on, it's making me smile because, you know, I looked at the photographs the other day. We could never do that at the moment. So wasn't that a lucky break that we had got that out? And there were 22 recommendations in that report. And I think it's fair to say it was written in a very user-friendly way. So the policy team said at the beginning, well, that's not how you write policy documents. And I rather naughtily said, well, perhaps that's why most policy documents sit on the shelf or in someone's hard drive and they don't get used. Let's make this possible for any woman to pick up and read and understand about what she can do to be part of the solution. Because I believe really strongly that women are 51% of the population, but they influence everybody else in society. So if you get it right for women, you get it right for everybody. And there's so many aspects of women's health where they're not ill, they just need a bit of help, guidance, maintenance. You know, you're not ill when you're pregnant, you're not ill when you're going for contraception, you're not ill when you're going for an abortion either, you're just trying to get on with your life. And I think that history has shown over and over again, when you educate women to look after their health, they do it very well. So I think we're missing a trick if we don't recruit them. So one of the things I want to do is to get those recommendations over the line. And we've already got a few, because do you remember one of the ones that we called for, because you were very good, you proofread that thing, every bloody edition of it. It was to get telemedicine abortion and mifepristone to be given at home. We talked a lot about the importance of post-delivery contraception, and you've worked with me over this last year to help me get trainer status so that we could train midwives to provide post-delivery contraception. That brings me to another point I should make. I mean, never waste a good crisis, because COVID may have had disastrous consequences for our country and for the world, but it achieved telemedicine abortion and it's achieved post-delivery contraception. So carpe COVID for those two things. So that's been good. And so I really want to implement the other ones. And it's rather lovely that we're having this conversation today, because it was only just earlier this week that we heard, did we not, that desogestrel, the third generation progesterone-only pill, is going to be available in pharmacies. And I think it was 5 years ago or 6 years ago, do you remember, when we went to see a very famous captain of industry, I won't mention her name, but we wanted her to get her company to help us push this across the line. And she was anyway, we both left that meeting and I remember you saying to me, let's go and have a drink, Lesley, because I don't think she's going to help. But I feel that by persisting and for the right reasons, this is what women need, we've managed to get that over the line. So I had a lovely text from Alan Boyd yesterday who said, I think Asha and you and I can pat ourselves on the back that it's now been achieved. So it's those sorts of things, getting those other things. And also wearing my FIGO or international hat on, you know, we've only got another 9 years until 2030 and the end of the Sustainable Development Goals. And the one that I feel most passionately about, and I know you do too, is SDG 5, which is achieving gender equality and empowering all girls and women by 2030. And I firmly believe that the only way we're going to do that is by educating girls and women about their health, because when we do that, we educate them, they really empower the rest of society. So I don't suppose I'm going to be able to achieve that, and I certainly won't do it solo, but the collaborations that I've built up over the years and the colleagues and the friends that I've made who believe that too, together we'll get somewhere along that road. We may not get quite to the end point by 2030, but we will be well on the way. And perhaps most importantly, we will have recruited lots of people to follow on after us to continue the work. Because as I said, you know, you can't do anything in life that's in a sustained way if you don't collaborate and encourage the next generation to come along and fight the good fight and get to the goal.
But that's what I like the most about you, is your vision and the breadth of it. It's fantastic. It's not narrowed on any one bit, which is what I absolutely love. So well, thank you very much.
Lovely. It was, you know, it's not difficult when you've got colleagues like yourself. You know, Janice Anna Glazier, all these people, not just women either, men as well, who really want to help and can put their own views and their own importance or their own egos to one side and say, look, that's where we've got to try and get to. And I think the other thing is that recognizing that, and that's where the Michael Marmot thing was so important to me, recognizing that you can't do everything as doctors. You've got to collaborate with all sorts of other organizations in society to do it. So when we set up the Women's Health Task Force with the Department of Health during my presidency, we worked very hard, you and I, not to have too many doctors round the table. We had the police round the table because of the violence issue. We had the Department of Education there because we've got to change the syllabus. We had all sorts of captains of industry because we needed their help to do things. We had people from NHS Digital because you can have all the most wonderful information in the world, but if people can't access it, then it's no use at all. So I think multidisciplinary collaboration is really the name of the game. And of course, it's logical, simple, really, when you look at it, because, you know, women's health goes right across a life course. So of course, it's got to span all these different areas as well. So I think that's what I'm really focusing on, persuading more and more people that it's not about illness, it's about preventative agenda, which will also mean that we can save a lot of money. So I'm hoping that post-COVID, one of the, you know, because we will be under constraints because of the enormous national debt we have in this country and every other country has, that I'm hoping that common sense and accounting and recognizing that doing things in a preventative way to reduce the cost of the illnesses later down the line will for the first time be possible. So I think it's a bit of a watershed. You know, 1948 was the watershed when Nana and Bevan set up the NHS. And I think 2021, 22 is going to be a bit of a watershed as well, because we've got to think about things differently. So my biggest hope is that we can actually realise those one-stop women's health centres or clinics that you and I have talked about so often, and ensure that they are staffed by people who really care about women's health. They don't have to be in every hospital or in every little town, but they need to be accessible. And really staffed with people who really care about this and want to make a difference, and want to empower women to look after themselves.
Great vision. So thank you very much, Lesley. Congratulations once again.
Thank you again. It's been absolutely wonderful talking to you, as always, Asha, but thank you for this great honour. I've got it after my name on my CV now.
Yes.
Also that I'm a trainer to put in implants and coils.